Welcome to this PAME webinar titled Global Attitudes and Practices in Counseling About Sudden Unexpected Death in Epilepsy, or SUDEP. For those of you who might not already know, PAME stands for Partners Against Mortality and Epilepsy, and PAME is a collaboration between families and healthcare professionals to promote understanding and drive prevention of epilepsy-related mortality. PAME organizes an annual conference and provides ongoing educational content throughout the year. So please check out our website, pameonline.org, for more information. And this is how today's webinar will flow. I'll have the pleasure of introducing our moderator, Dr. Robyn Whitney. She'll provide an overview of the topic, and then we'll introduce our two speakers. We hope to save about 15 minutes for discussion, so please use the Q&A function on your screen and feel free to also use the chat to talk with other participants. And before I introduce Dr. Whitney, I want to thank, Anne, can you advance the slides for me, please? Those are our speakers. Yep, right there. And before I introduce Dr. Whitney, I want to thank Leva Nova for sponsoring this webinar and for being a really important industry partner to PAME. I also want to remind everyone that our next conference, next slide, please. Yeah. Our next conference is this December 4th and 5th in Los Angeles. So please check the website for more information. Okay, and now I'd like to introduce Dr. Whitney, who is a pediatric epileptologist and neurologist at McMaster's Children's Hospital in Canada. Prior to this, she worked as an assistant professor of pediatrics at the Hospital for Sick Children, where she received the William Hawk Award for Excellence in Clinical Teaching in the Division of Neurology. Dr. Whitney has a clinical interest in the medical and surgical management of kids with medically refractory epilepsy, particularly those with genetic developmental epileptic encephalopathies. She has a recent research interest in the epilepsy genetics, epileptic and tuberous sclerosis complex, TSC, and SUDEP. She has become an expert on SUDEP communication issues and recently co-published an important review article on the gaps around counseling. And PAME is very fortunate to have her as a new member of the Conference Planning Committee. So thank you, Dr. Whitney, for being here and moderating, and I'll pass it over to you.
Thank you so much, Gardner, for inviting all of us today, and to Anne as well for helping to organize this webinar. It's really an honor to be here today. So I'm just going to share my screens and hope there's no technological difficulties. And just a second. You can see my slides, hopefully.
Yeah, it's great.
Awesome. So as you all know, the topic of this webinar is SUDEP Counseling, Global Attitudes and Practices. So to begin, sudden unexpected death in epilepsy is the most common epilepsy-related cause of death in persons living with epilepsy. We know that SUDEP unfortunately affects 1 in 1,000 people living with epilepsy each year, and that the most important risk factor for SUDEP is the presence and frequency of tonic-clonic seizures, although other risk factors do exist. The American Academy of Neurology, as well as the American Epilepsy Society and National Institute for Clinical Excellence in the UK, all recommend that SUDEP be discussed with all persons with epilepsy and their caregivers. The American Academy of Neurology, as well as American Epilepsy Society, recommend that persons living with epilepsy and their caregivers are informed about SUDEP at or soon after an epilepsy diagnosis. Healthcare providers should inform people living with epilepsy and their caregivers regarding the incidence of SUDEP. They should also inform persons living with epilepsy that seizure freedom is associated with decreased SUDEP risk. Despite the recommendations from the American Academy of Neurology, as well as American Epilepsy Society and the National Institute of Clinical Excellence, some clinicians and healthcare providers are yet to embrace these guidelines fully. There have been a number of studies that have examined the past and present state of SUDEP disclosure. However, most studies have been focused on very certain geographic locations alone, such as Canada, the United States of America, UK, India, Italy, Saudi Arabia, etc. A recent study, however, examined practices of SUDEP communication among healthcare providers on a global scale. This study was entitled Counseling About Sudden Unexpected Death and Epilepsy, a Global Survey of Neurologists' Opinions, and it was published in Epilepsy and Behavior in 2022, and the lead author was Asadi Puya. So this survey surveyed 1,123 neurologists, and this is a very difficult thing to do, to get this many neurologists to respond to a survey. From 27 countries, and they were looking at SUDEP disclosure. Table 1 just shows the baseline characteristics of the participants. As you can see, the median age of respondents was 42, and about 55% of the respondents were female. Most were active adult neurologists, and about 20% were pediatric neurologists. Most of the respondents had been in clinical practice for at least 10 years, 64%. And most participants were seeing 5 to 50 patients with epilepsy each month. As you can see, the location of the work was predominantly in an urban setting, 95% of participants. And most participants actually were in a non-academic setting versus an academic setting. What did they find in this survey? Well, they found that a total of 41% of respondents discussed SUDEP with persons with epilepsy and their caregivers rarely, less than 10% of the time. Only 12% of respondents discussed SUDEP with most patients and their caregivers living with epilepsy, aka 50 to 90% of the time. And around 30% discussed SUDEP with some persons living with epilepsy and their caregivers. Most respondents felt that verbal discussion was preferred, 72%, and discussion was best after developing a trusting relationship with the individual with epilepsy and their caregiver. Respondents felt that SUDEP should be discussed if the seizures were refractory, or if there were frequent tonic-clonic seizures, and or if there was poor compliance. They did find that practicing in an academic setting and having an epilepsy fellowship positively influenced whether SUDEP was disclosed or not. And SUDEP was not discussed by some because they felt that it would erroneously cause excessive anxiety and worry. And we know from previous literature that this is not the case, or if they felt that SUDEP was felt to be rare. And as you can see, there were global differences observed as demonstrated in table 3. And I've also just illustrated in the table below the rates of SUDEP disclosure from different areas across the world. We can see that there's highly variable rates of SUDEP disclosure when we compare different parts of the world. For instance, South America, North America, there were higher rates of SUDEP disclosure when compared to Africa, the Middle East, and Asia. Regional differences in SUDEP disclosure may be related to differences in education, differences in legal frameworks, ethics. Spiritual attitudes may also account for global differences in SUDEP communication. And we also know that access to resources and healthcare providers may also differ globally, which leads us to the topic of today's webinar, which is SUDEP Counseling, Global Practices and Attitudes. And it's my absolute pleasure to introduce our two speakers today. The first is Dr. Suvasini Sharma, who is a pediatric neurologist and epileptologist working as a professor in the Department of Pediatrics, Lady Hardinge Medical College, and associated Kalwadi Saran Children's Hospital in New Delhi, India. I've had the pleasure of working with Suvasini on several research projects, and her research interests are in dietary therapies for childhood epilepsy, infantile spasms, and SUDEP. And importantly, she is a member of the International League Against Epilepsy SUDEP Task Force. I also have the pleasure of introducing Tolu Olaniyan, who is the CEO and director of the Pretola Global Health and Consulting. She is a registered learning disability nurse with a special interest in epilepsy. She has a degree in LD nursing from the University of Southampton and a master's degree in epileptology from King's College in London. She is passionate about improving epilepsy care globally. She was born in Nigeria and later migrated to the United Kingdom with her family, giving her an international understanding of the complexities surrounding epilepsy in low and middle income countries. Through her work with the Pretola global health and consulting, she actively works toward building epilepsy capacity in these countries. She has successfully delivered high-quality virtual epilepsy training to impressively over 1,000 clinicians and healthcare providers in low middle income countries. She also introduced masterclasses in 2022 and most recently delivered a SUDEP masterclass to over 300 participants. She continues to lead on service improvement projects to establish evidence-based care pathways in the United Kingdom and internationally, and she is the co-lead of the ILAE nursing section for Europe region and UK. And so without further ado, Dr. Suvasini Sharma will start first, and then we'll have Tolu present as well.
Very good morning to all of you. I would like to thank PAME, Robyn and Gardner for giving me this opportunity. So in the next 15 minutes or so, I'll talk about our experience in India with SUDEP communication to patients with epilepsy and their caregivers. As Robyn has already mentioned, SUDEP is an important cause of mortality in children with epilepsy, and the disclosure of SUDEP risk has been endorsed by multiple neurological societies. And the reason why physicians are hesitant to counsel is that they worry that counseling may increase worry and anxiety of parents. But studies have shown that information on SUDEP increases the overall understanding of risk factors about this. And the parents are relieved to know about the overall low risk of SUDEP, and they're able to prepare for it and hopefully prevent it. And SUDEP counseling has known to lead for motivation for better seizure control strategies, including drug compliance. So there have been a number of studies from the West, starting with this first study from the UK by Gayatri et al. This was a study on parental and physician beliefs regarding the provision and content of SUDEP information. And this was done nearly 14 years ago in 2010. And what the researchers found was that the majority of pediatric neurologists, like 3/4 of them, were providing SUDEP information only to a select group of parents of children with epilepsy. So it was a selective SUDEP disclosure risk. On the other hand, 91% of parents expected the pediatric neurologist to provide the SUDEP risk information. So there was a big divide between what parents expected and what was actually being done by the doctors. And similar experience from Canada by Dr. Rajesh Ramchandran Nair, both that there was an adult study as well as a pediatric study. And in both studies, what was found was that patients and caregivers expect a full disclosure. But this is not being done by the doctors in the way, generally thinking that basically ultimately it might be the anxiety, but from the parents' side and the family side, full disclosure is expected. In one study from Malaysia, seeing the Asian scenario, again on pediatric epilepsy by Fong et al. And it was the similar situation that most Malaysian parents of children with epilepsy wanted information on SUDEP for themselves at the time of diagnosis, and some of them even wanted it for their children. But again, the doctors were not doing it. So with this kind of a scenario, in what was the scenario in India? Basically, even in India, we have two main societies for this: Indian Epilepsy Society, the Association of Child Neurology, Indian Academy of Neurology. All these professional Indian bodies have also recommended communication regarding SUDEP. The experts in India also feel that this has to be communicated. However, by and large, this is not practiced. One of the reasons is that epilepsy is not treated only by neurologists, but also by general physicians and pediatricians, and there is a lack of awareness amongst these physicians treating epilepsy. Also, another problem is that our clinic settings are really very, very busy. In a government hospital setting, in a half-day clinic, most of us would see around 50 patients in a day, 50 patients in a clinic. So it's not possible when you're getting only 5 to 10 minutes per patient to spend that much time on counseling. And even in the private scenario, in a half-day clinic, people would see 20 to 25 patients. So it's difficult finding time. And of course, there is always a fear of patient and caregiver anxiety. And another thing, I suppose, is a cultural aspect that overall talking of things which are not good, like death is considered taboo or ominous. You talk about a bad thing and the bad thing may happen. So the parents, we feel that families don't want to discuss death. And this is a possibility, maybe not just in epilepsy, but even in other chronic conditions with the risk of mortality. Mortality discussions are kind of not as open in the Indian context as compared to the West, I think. So this was one study from the adult neurology setup. So this was from All India Institute of Medical Sciences, New Delhi. This study looked at the effect of providing sudden unexpected death in epilepsy to persons with epilepsy and their caregivers. So basically, they had a historical control group, which they compared with a set of patients whom they gave SUDEP information. And what they wanted to see was that, is this information, first of all, is it causing any anxiety or depression? And as in other studies, they found that there was no increase in anxiety or depression. But interestingly, they also tried to find out if it is causing a positive change in their behavior as related to their epilepsy management. And they looked at the change in drug adherence by the modified Morrisky medication adherence scale. And what they found that there was a slight improvement in this adherence. It was not statistically significant, but there was a trend towards patients taking their medications and adherence improvement, which is a good thing. So overall, no harmful effect, but a positive effect in patients on their handling of their epilepsy. So with this background, this was a study done in our center. So this was a single group pre and post intervention study. We enrolled parents of children attending the epilepsy clinic in our hospital with the diagnosis of epilepsy being there at least for 3 months. And so patients, the participants or parents of children aged 3 months to 18 years and with a minimal education level of grade 5, because we providing written information as well. That is why many of our parents are illiterate and lower level also. So we wanted to start with something because this was our plan with at least a grade 5 literacy level. And we excluded parents of children with only absence seizures, or if the parent themselves is having epilepsy, or if they're having a known psychiatric illness. So what we did was a 3-phase counseling. So they were first provided a written material to read, and then there was a video which they could watch. This is the video. This is one other our PG resident student whose project was this. Oh, there is no audio in this. Anyway, it was in Hindi. And this was followed by a face-to-face counseling session so that whatever doubts they had after this was clarified with the face-to-face discussion. So the primary outcome was proportional. We had a list of epilepsy-related caregiving behaviors like giving medications, missing medications, giving on time, taking medications on travel, the rescue medications, etc., and sleep and things like that. We had made a list of factors which we felt was relevant to the child's epilepsy care. So any change, a positive change in 2 or more childcare behaviors was considered a good outcome. And the secondary outcomes was there any increase in anxiety or depression? So we used the DAS-21, which is the depression anxiety stress score, before and after SUDEP counseling. So before counseling and 1 month after counseling. And we also took an open-ended feedback on the content and process of SUDEP counseling from the parents. So in this study, which was done over a period of 15 months, 120 parents had participated. And 58% of them were mothers and the rest were fathers. And most of them were educated up to middle or high school level. We did not have many college graduates, but that's because our hospital caters to relatively poor and lower middle socioeconomic status patients. So we do not get too many very highly educated parents in our scenario. And out of this big lot of 120 parents, and only 5 of them had a partial knowledge of SUDEP, prior knowledge. So the awareness amongst families was also low, though most of them said that they had definitely an overall fear of mortality after witnessing the seizure in the child. They always did fear in their mind that maybe my child would die, but they were not aware of SUDEP as an entity. So the age range was that the majority of them were between 1 to 12 years of age. We had fewer infants and adolescents. And the seizure, so most of them had seizures about 1 to 5 times per year, but about a third of them had, about 1/4 of them had daily seizures. So because ours is a referral center, we usually get more difficult to treat seizures and not the very simple epilepsies. So our majority of the patients were on polytherapy. Only 16 out of 120 were on monotherapy. And 38 out of these 120 children had nocturnal seizures, which we know are as risk factors for SUDEP. And regarding the syndromes, so the epileptic encephalopathies like West syndrome was seen in 30% of the patients. The others comprised of Dravet, selects, or benign child epilepsy with centrotemporal spikes, JME, so whole spectrum of epilepsies, and including almost 1/3 non-syndromic epilepsies. The comorbidities included 17.5% of them had cerebral palsy, 55% of them had developmental delay or intellectual disability, and a small proportion had autistic features, hyperactivity, and sleep problems. So once the counseling was done and we did the pre and post, looking for whether it was an increase in depression, anxiety, or stress, and what we found that there was really statistically no change. There was no increase in depression, anxiety, or stress, which was very nice to know. And looking at the change in childcare behavior and practices. So at least, looking at, there was definitely an improvement in compliance in terms of fixed, at least they're giving the drugs in the fixed timings, not missing doses, and supervision of some of the activities which we had advised, including nocturnal supervision. So ultimately, there was an 85% change in at least two behaviors. And like having a seizure action plan in place. Not all of it was related to SUDEP, but generally better epilepsy management. I think that was helpful, having rescue medications at home. So when we took an open-ended feedback of the counseling, and an overwhelming majority of them, 150, like almost 95% of them said that SUDEP should be discussed definitely. And regarding when it should be discussed, they did not want it at the first visit. They said, we need to be more comfortable with the diagnosis of epilepsy first, because it's too much information to take in at the first visit. Once we are more comfortable that this is what it is and this is what we need to do, maybe in the third visit or so, when we are comfortable with you and with the diagnosis, we want to hear about it. And so they also felt like their Western counterparts and counterparts in other countries that it should be discussed regardless of seizure control. Do not just talk about it to people who are at high risk, but also to everybody. Because this is a fear in all our minds that our child may die. It's in fact reassuring to know that the risk is so low, and we would like to know what we can do to prevent it. So it was a kind of an information which they felt empowered with. And regarding how it should be counseled, they all said that this was a good system, that they were able to first read at their pace and see the video, and then think about it, and then talk to the doctor. Because if it's just a face-to-face discussion, sometimes the information is overwhelming to take in, and they can see that the scenario is a very busy clinic, and they sometimes feel that they cannot ask. This way, with a prior preparation in their minds of what it is and what they can, then they felt better that this was a better system to do a face-to-face interaction. They do want a face-to-face interaction, but getting a prior knowledge of it with a information leaflet or a video was a good idea. So to summarize, 96% of them wanted SUDEP discussion, and there was no change in emotional distress after the counseling. And in fact, 85% of them reported a positive change in their epilepsy-related behavior and childcare practices. And the majority of them want the SUDEP information when they are comfortable with the diagnosis, irrespective of seizure control. And they do want a face-to-face discussion after a written information and any way of implementing this, imparting this knowledge. So we are now having this ongoing study, like, should we talk to the young people themselves? So, because this is another thing that anyway in India, we have a more kind of a paternalistic attitude to kids. Kids don't really leave home, they are there. So they're very protective attitude that should we even talk about it. So we have now, what we've done is that this SUDEP information is actually incorporated within overall safety information. So we say we are going to tell you how you can be safe. And this would include everything like injuries, drug interactions, and drug abuse, everything. So SUDEP is one part of all of this. So it's not like suddenly you talk only about death. And this is a study which we're doing in young people aged 13 to 18 years without any significant intellectual or psychiatric comorbidity. So what we're doing is we are having a similar written information, video, and face-to-face counseling about the safety aspects of epilepsy. We're not labeling it SUDEP. We don't want to scare them or the parents. But we just say we're talking about safety, and our outcomes are changes in the similar depression, anxiety, stress scores, changes in epilepsy and safety self-care practices, and feedback over the overall counseling process. The study is still ongoing. And so to conclude, I think we again reiterate that even in our part of the world, SUDEP counseling needs to be imparted to all parents and caregivers of people with epilepsy, irrespective of seizure control. But they do need opportunity to clear doubts and dilemmas in a face-to-face interaction. And so basically, there is so much stigma related to epilepsy in our scenario, and then you add death to it. So they get scared, but I think it's good to bring out these fears in the open and talk about it. And we found that it leads to positive change in childcare supervision, and the parents are motivated to take steps for prevention. And there is really, really no change in parents' emotional state, and we are worried unnecessarily whether it will cause anxiety. But I think the major challenge to make it universal is our time and resource constraints. That's going to be the big challenge in our setting. Thank you.
Thank you so much, Suvasini, and for this really important work that you're doing. Because I think it's, a common misconception that if we inform patients and caregivers about SUDEP, that it's not going to change anything. And you show that it doesn't improve childcare behaviors, compliance with meds, and we know that non-compliance with anti-seizure medication and having frequent seizures increases the risk of SUDEP. So really wonderful work that you're doing, and thank you for speaking and leading this. Tolu, if you want to share your slides now, thank you.
Hello, everyone. I hope you can hear me. And my name is Tolu Olaniyan, and I'm from the CEO of Pretola Global Health right here in the UK. And I'm here to share with you what we're doing with regards to having a discussion around SUDEP, discussing SUDEP and raising awareness on SUDEP in low resource countries. So Pretola Global Health is an organization where we're really passionate about addressing the awareness and treatment gap of epilepsy, awareness, treatment gap through education and research, and also empowering clinicians and individuals as well to develop local strategies to improve epilepsy care in low resource countries. And as we know, epilepsy is a treatable condition for about 70%, when gotten right, about 70% can be seizure-free with the right treatment. But we do know that 80% of those numbers live in low-resource countries, and majority of them do not have access to treatment. And the impact on family life, the impact on the life of the individual can be quite significant, with a high mortality rate being seen in that population as well. And there is a lack of awareness and clinical expertise in a lot of those countries. So it's really important that we provide the training, and we support them in different ways. And one of the ways we do that through Pretola Global Health is to provide training, expert training to clinicians and non-clinicians as well about epilepsy. Okay, and so far we started in 2021, and we've made a whole lot of progress, and there's still a lot of work to do over the years. We started with our first training that was just attended by 54 clinicians from 12 countries, up onto our current training that is ongoing at the moment, being attended by 720 clinicians from 55 countries. Today, I really want to talk about the SUDEP masterclass that we had last year, and the feedback we got from it, and why it's really important we we do not shy away from this conversation, and we do raise awareness about SUDEP in low resource countries, because there's a whole lot of stuff going on there, a lot of barriers to it, but we do not let that stop us. We have to continue, and we have to push forward towards raising awareness about epilepsy and also SUDEP as well. So the SUDEP masterclass was held last year. It was a virtual training held with over 300 and over 300 participants attended. And I do want to say thank you to Danny Deed and Rowe Foundation that sponsored that training. As a result of their support, people were able to attend the training for free from low resource countries, because we're so passionate about removing the barriers to training. And we know that financial barriers is one of the major barriers that keep clinicians away from being able to access the training they need from low resource countries, because they can't afford to attend trainings. They can't afford to, go out of their country or out of their area, remote area, to access the training they need. So through our trainings, we're able to bring that information to them. So we ran the SUDEP masterclass last year, and we covered three main topics. We of which stigma ran through the three topics we covered, and we started from an overview of sudden unexpected death in low resource countries. We look at the research, and from what was presented earlier by Robyn and Suvasini as well, that we could see that there's a lack of resource, lack of data from these countries. So it's really difficult. We know data actually drives innovation. Data drives care treatment. Now, how do we develop new pathways if there's no data? Hence why we needed to dig into that, to look at what the research is saying and the data is, was talking about with regards to sudden unexpected death in epilepsy. So we are quite passionate about increasing that. We're passionate about working towards, research that would start, unpick those a bit further. And we also looked at the risks and assessments and talking about how can we have conversations with families as well, and also about SUDEP in pregnancy. We'll talk a little bit more about those. Now, some of the key points, which is not limited to this, raised at the training, was more of lack of awareness. General lack of awareness about epilepsy in itself in a lot of countries. And then when you now add SUDEP to it, there's a whole lot of lack of awareness about sudden unexpected death in epilepsy. And I do remember liaising with a neurologist in a low resource country about we're talking about SUDEP, and said, I've not seen it. I've not seen SUDEP. And I thought, I'm sure you have. You probably missed it. You've probably missed it, and there are a whole lot of barriers to that. It was a shock to me. I just sat back thinking, why? How come? But then I thought, hang on, he's missed it, and there are issues to that as well. Also, myth and cultural misconceptions about epilepsy in itself, in the sense that there's a whole lot of, a lot of um, untruth truths, things that they've held on to over the years, that that's been passed down from one generation to the next generation, that there are myths about epilepsy, and those ring true to them more than facts. And so it's really important we create awareness about epilepsy, myths about the fact that epilepsy is contagious, or it's linked to an animal, or it's a spirit being. And then you now add SUDEP conversation to that. That just blows it. It opens up a whole kind of worms in itself. Misconceptions and practices, and also religious practices, in the sense that part of the ways through which we can identify if someone died through SUDEP is by post-mortem. But we know that in some countries and with some religion, you can't defile the dead. So they would bury their dead within 24 hours. So how would you be able to identify if that person died as a result of sudden unexpected death in epilepsy. Hence why you may end up getting a clinician saying, I've not seen someone with SUDEP before. Not because they're lying, but because they've not thought of it from that perspective, and they've not been able to actually go back to the history or go back to, to unpick the situation surrounding the death of that individual. And then also we're talking about stigma. Stigma is quite stigmatization of people with epilepsy and their families in the community is quite profound. The impact of it can be quite profound, leading to community isolation and the thought of the fact that our loved one could die as a result of that is also something quite difficult that could be quite difficult to comprehend. We're talking of lack of access to care, lack of access to medication, and also the right information as well, and the lack of skilled experts in those countries. And I added this point as the last one, which is fear. Now, fear drives practice in some ways, in the sense that when you think about the myths, when you think about everything else, it all points down to fear. So we feel when we do not understand something, we're afraid of it. And hence why it's really important that we raise awareness. The more people know of it, the more it reduces fear, and the more they are equipped to be able to handle their condition. And the more they know about sudden unexpected death as well, the more we can actually eradicate some of these issues in the community. So fear drives, practice misconceptions, drives myths and all of that. So we do need to address it. Now, with the training, it was a 5 hour long training because we had the three topics to cover, and we had some feedback. And the training was attended both by clinicians and non-clinicians alike. And I wanted to share some of the feedback we received so that we know that people actually do want to know. Because one of the main points we covered on the day by our three speakers and during the Q&A of the masterclass was, do people want to know? And the question and the answer was yes. Everyone wants to know. Now, how we say it, how we pass that information along is very important. But everyone wants to know about their condition. They want to know how to keep themselves safe. Now, it's almost impossible for people with epilepsy and their families to be equipped to do the right thing if they do not know what the risks are. So we do need to have that conversation. So it's not, the question is, should I tell them? The question is, how do we, pass the information? And it needs to be passed with compassion. It needs to be passed with understanding. It needs to be passed thinking about what's going on around that individual, so that we can make sure we're supporting them right. And getting the information right to them. So after, the feedback we got from them, we asked, from the training, what percentage of the information we shared on the day was new to them. As you could see, nearly 37% said that 75% of what was discussed on the day was completely new to them. And nearly 40% said 50% of what we discussed on the day was new to them. That means that there's a need for us to actually keep talking. We have to keep raising awareness about sudden unexpected death in epilepsy. And did the content improve your knowledge on SUDEP? That's the feedback we got of those that completed the feedback form on the day, right there and there. You could see that they want to know. It improved their knowledge. So imagine if we could do more to be able to raise awareness and increase knowledge around SUDEP. Just go to if you're a person with epilepsy or a family carer, did the content of the presentation help you to identify ways to manage and reduce SUDEP risk for your family member? You can see that's what we got. So we do need to continue with our training, and from the clinicians as well. 100% of them that completed the feedback form felt that, the presentation, the training did help them to identify ways they can improve their practice in their countries. Now, the feedback we received on the day was quite, um, reflecting afterwards. It was more or less for me that we can't stop. We have to. It is really important that we do this work. It's really important that for us to, um, you know, keep people safe. People with epilepsy safe, we do need to empower clinicians. We do need to empower their families and the network around them. And we do need to empower the individual as well to be able to make the right choices to inform their care. So the feedback we received on the day, some of them are here. Someone said, I would include SUDEP as part of the education we provide so that people are aware of it, as this was excluded in all presentations they did given in their community. Um, and also, someone said, so informative, and I've been given knowledge of things I did not know of. It was really good. I've enjoyed it. Let's hope next time we'll have more information than this, because they want to know more. So the fact that we can't, it's an assumption that people do not want to know. And it's also an assumption that clinicians don't want to pass, do not want to tell people about SUDEP. They do, but sometimes they don't know how to do it. They don't know how to have that safe in that conversation in a safe space, as well. Okay. And someone said, this masterclass has been a life-changing experience for me as both a survivor and also a psychotherapist. It has not only enriched my personal journey, but also expanded my professional horizons as well. A lot more feedback we got on the day. Excellent opportunity to learn more from the best practitioners. And I'll go into the next questions we asked as to what are you going to do about it? Because we do more than just giving the information about SUDEP. What are you going to do about it? And someone said I'm going to do more studies, more research on it, which we need. In low resource countries, we need to encourage that. We need to get the data out there. We need people to look back into what they're doing, see if they can identify patterns and develop tools that would enable that conversation and also help to reduce risks in their practices as well. Someone said, I'll write to the hospital management addressing SUDEP. I'll ask for their help in awareness campaigns, and also request for epilepsy drugs, which were part of the issues raised during the training as the lack of medication, anti-seizure medication in some of their countries. We also, because we shared guidelines, we shared information from Danny Deed websites and from other, SUDEP Action and other organizations that we knew, they've got resources. We share them with the practitioners as well, so that they could start to think about how they can, create tools that would work for them in their practice. And this last bit was more, I felt was quite powerful. Someone said, I'll never fear death, but I will make sure I know all about the triggers and work with them. That's what we want. We want people to understand their risks and work with it. So what next for us at Pretola? There's a whole lot. We're not stopping. There's a whole lot to do, as you could tell. The need is huge. The need is great, especially across the world, globally, and much more so in low resource countries. So we're going. We're not stopping. Our next training has started in February, and like I said, we have 720 clinicians on it. We actually taught on SUDEP on Saturday, a couple of days ago, and the feedback, was still great as well. And we still have Rowe Foundation and Danny Deed supporting us on this, because they do believe on our purpose, and it aligns with their goals as well. So it's great having them on board to equip 720 clinicians from 55 countries to this. We're doing some research paper projects. We're working on research papers. We're in the process of publishing some more, and we're looking towards developing a safety checklist that would address risks associated to low resource countries, because there's some risks that they face that are more prevalent in some of those countries compared to like the UK, for example, going to fetch water in the well. You wouldn't do that in the UK. You wouldn't go to the stream to fetch water. But then those are some of the risks that people with epilepsy could face in some of those countries. So we're working towards developing a checklist that would work and trialed and hopefully address some of those risks. And thank you. I've come to the end of my presentation. Thank you, Gardner, and the team for having me.
Thank you, Tolu. This is amazing work that you're doing. I am so impressed. Honestly, it's so important. So thank you for sharing all of this today with us. I think we have about 10 minutes or so for questions. I do have a question. Well, one thing I actually was thinking about was with regards to our trainees as well, our residents, our fellows, our medical students. There was a study published, I believe, in 2022 or 2021, looking at education of trainees with regards to knowledge of SUDEP and having the opportunity to see, other healthcare providers counsel about SUDEP. And less than 50% of trainees, both internationally and from North America, had the opportunity to even counsel about SUDEP or see another healthcare provider counsel about SUDEP. And less than 50% had good understanding about SUDEP as well, which is obviously like very concerning if these are our future healthcare providers who are going to be seeing, patients with epilepsy. So I'm wondering, how do you think that we can educate the future generation of healthcare providers? And it's not just neurologists or nurses, but in some of these countries, family doctors or pediatricians are caring for patients with epilepsy. So curious to hear your thoughts on this, either Suvasini or Tolu, what you think about that.
Do you want me to start?
So I think
You go ahead. Go ahead.
Go ahead, Tolu.
I would say it's important we start early. Okay, so we get the word out there for nurses, student nurses, medical students, basically anywhere we get the word out there. And that's why on our current training, we've partnered with a foundation in the Gambia, FESGAM, that's Foundation for Epilepsy Stigma Support in the Gambia. And they've actually got over 120 medical students and student nurses on the training, because it's really important we start early. And in some of those countries, they do not have, access to the experts. For example, in Sierra Leone, there are just about 2 neurologists in that country. So you can't focus on 2 neurologists alone to deal with all the adult and pediatric stuff. So we really need to change our plan, which is to actually start to get the word out there to neurologists, psychologists, everyone right from the training onset. Yeah.
Suvasini, did you have any other further comments for that question?
No, I think so. We have a pediatric residency program going on in our hospital. So when we train them about epilepsy, so I think it's like we started making, like she mentioned, a checklist, safety. We have a counseling checklist. So we tell the residents that you make sure that all these things are talked about. So which includes, like, what to do in case of a breakthrough seizure or a seizure management at home, rash, side effects. So also includes SUDEP in that. So then they're also curious what is SUDEP, they learn about it, and it becomes part of, and then you document that this has been communicated.
Yeah.
So I think that education has to start right when they're learning about epilepsy.
Exactly. And trying to, you mentioned just trying to normalize the conversation as part of a regular, seizure safety and counseling, that SUDEP should be a part of it. And just normalizing the discussion, I think, is, super important. There are a number of questions in the chat as well. Gardner, did you have any specific questions? I see you writing down like
No,
furiously.
no. The chat questions are really interesting. I think you should have at those because they're
Okay.
kind of along the lines
So I
of.
know, sorry, Suvasini, you've answered some of them, but I'm from Peter Bloom. Is there information on the percentage of persons with epilepsy who have died from SUDEP when they or their parents have received good SUDEP information and counseling? Suvasini or Tolu, do you know of anything about this? I haven't come across any studies that have looked at this. And, you know, some people will argue that, oh, like telling about SUDEP doesn't prevent about SUDEP and use that as their argument in terms of not discussing it. But it would be very hard to do a study to prove this point. And we know that there were questions in the chat about preventative measures for SUDEP in terms of reducing seizures, improving compliance. There's some evidence that nocturnal supervision or the use of a listening device can be protective as well. So unfortunately, there's not great evidence for that, but we all feel it's very important that we inform our patients and families about the risk of SUDEP. And as Suvasini showed in her study, that positive changes can be made in childcare behaviors when families are informed about SUDEP, taking medications on time, adhering to their seizure action plans. So it does positively change behavior, which again is a misconception that it doesn't. An interesting question from Diane Milborn, a very important question. Are coroners educated about SUDEP?
So I don't know about so in India, we usually only have medical legal autopsies. We'll have autopsy only if there's a suspicion about foul play. So that is the thing. Like, I don't think they're educated about SUDEP, and it is an issue. Like, we don't have routine autopsies for unexplained deaths. If the doctor certifies that it's they think it's natural, then people won't go ahead with an autopsy.
Yes. Yeah. There was a paper from North America that has like guidelines in terms of investigating sudden death at least in North America, for coroners. But I personally don't know what kind of education they receive. Tula, do you have any comments about that, or Gardner?
No, I don't think there's a general education to coroners about that. Even in the UK, it's one of our bugbears that we keep trying to push us to. There's need to educate them about it. So it's really important that we do as well, that we include them in that conversation. Even in the UK, apart from the coroners, we're talking of the medical examiners, because it's the medical examiners that will say, okay, this needs to go to the coroners. And if the medical examiners say it doesn't need to go, that doesn't, it doesn't happen. So we do need to get everyone involved and creating awareness about SUDEP there as well.
It's a huge issue here. I've heard about verbal autopsies being done in low-income settings as a way to kind of get a understanding of the scope of the problem, which is sort of interesting to me as we kind of do more and better research and surveillance. I wonder if that will be a tool used.
It'll probably work in settings where especially those where there's the restriction around religious practices where you can't defile the body and they need to bury their dead within 24 hours. So a verbal autopsy, having a conversation with the families and those, to find out the situation around and how the person, basically taking a bit of of general asking questions as to what happened to create a bit of a picture of what happened. That could be the answer to some of that. Yeah.
Thank you both. There's a question from Janet Romeo asking, how is the harvesting of brains addressed, considering this is the best way to try to figure out exactly what is happening and to prevent SUDEP? Any comments about that?
So I think autopsy studies have definitely helped us. I think I'm not sure about brain harvesting, but generally to find out, and it's not just the brain, but heart and lung mechanisms also. And so that have definitely helped us understand why SUDEP is occurring. Plus also, I think there's genetics of the brain tissue as well, to look at genetic aspects of SUDEP. So it's definitely for patients who have died of SUDEP, having an autopsy and in an academic setting is definitely going to help for future prevention, I guess, to understand more and learn more.
Yeah. And also, as you said, Suvasini, genetic testing is being done more commonly in the case of SUDEP and sudden cardiac death to identify if there's any, genetic risk factors, which is certainly important for other family members and counseling as well. There is a comment from Nicholas Okeo, who's from Kenya. Thank you for joining us today. In Kenya, we are expanding the scope of epilepsy management to the primary healthcare setup, since the clinical officers make up the larger group of healthcare providers and get in touch with the patient first before being sent to different cares. How do we ensure we even reach those in rural setups? Any comments on that?
That just buttressed the point I was raising about, training. We can't, the training can't just be to a specific group. You need to cast the training, education wide, because in some countries, like Nicholas said, it's very limited access. So we do need to make sure we're training the trainers so that the trainers can go back to their country and train their colleagues and increase awareness. The more we do that, that's the solution, really. The more we do that, the more we can improve care for people with epilepsy in those countries. Yeah.
I can see that somebody has their hand up, Philbert, but I'm not sure how to unmute them. Are we able to unmute, or maybe Philbert, if you can type your question in chat, because I don't have the capacity to unmute you, and I don't want you to think we're ignoring your question at all. There are several questions that were answered in the chat as well that maybe I'll just read out while we have a couple of a couple of minutes left. There's a question from Peter Bloom asking, what is the risk of an adult whose tonic-clonic seizures are controlled, but they have focal partial nocturnal seizures which continue? And Suvasini has just answered that, nocturnal bilateral tonic-clonic seizures are a risk factor for SUDEP. And I think, in that situation where the patient is having, focal seizures at night, there's always the chance that those focal seizures can become bilateral tonic-clonic seizures. So aiming for, seizure freedom in this situation would be important because of the risk of that. And we know that the risk is similar for those that have a focal to bilateral tonic-clonic versus primary tonic-clonic seizures.
Maybe one more, and then can help you close it up. Or I can. There were a few in there about resources, and we touched on those some, and I think that will be an ongoing theme that I look forward to hearing from all of you about. And Tolu, I love the idea of a checklist that you're developing. So, let's share these resources. I think it's exciting that we're having a global conversation about SUDEP counseling. This is really new, I think. And I think it's really important given that we have IGAP to follow, and that we all know that epilepsy mortality is a huge issue, and people with epilepsy are 3 to 4 times more likely to die prematurely, and that SUDEP is one of the largest causes. So I hope we continue this dialogue and work together to develop new resources and learn, Dr. Sharma, about the video or the like how these tools compare, and to keep our eyes on the International League Against Epilepsy, because it's exciting to see them. They have a task force, and we'll be releasing guidelines, hopefully. And so I think there will continue to be momentum. So I just can't thank you all enough for your leadership in this space. And for all of you for tuning in. It's great to have you here. And please reach out to us if you have further thoughts for other webinars or want to get engaged. So thank you. Robyn, do you want to say anything else before we
I
close?
just want to echo what you said, Gardner. Thank you so much because this is all Gardner's idea, this whole webinar today. So I can't thank you enough for Anne for organizing this and inviting myself and Suvasini and Tolu to speak about this important topic. And I agree, we're kind of just getting started, and it's a very, exciting to see all of these developments that are happening in many parts of the world, and the collaboration that's happening as well. So absolute pleasure to be a part of this today. And thank you again for everybody who participated in the questions and the interactions. I really enjoyed this session. and I look forward to future collaborations with everybody.
Thanks, guys.
Thank you.
Great day.